Thank you, Eva, for that kind introduction, and thank you for the invitation to this interesting meeting of the MSIF, and thank you to Siri, which perfectly, without having talked about this, touched on what I would like to start with a vision. If we would like to have better treatments, and if we start looking into this, and all the efforts which had been made during the last 20 years in determining new ways of treatment, would have come that far if they were not guided by a vision. And I think as the logo of the MSIF took it up very nice, we should all be unemployed by the time when MS is no longer existent, because then we don't need to work anymore for it. So great thing to go forward with. But how can we make it a reality? Of course, one thing which is very important, we need to get people involved. You as patient, we as neurologists, our fellow colleagues and other medical specialty, but also the lay public in general, because there are still some awkward arguments about the diagnosis of MS. Everyone should know what it really is about. So it needs awareness and education. And of course, it needs also the surrounding, the environment where which all this could happen. So effective and proper resource services in care for MS patients. And then, of course, it needs a lot of communication between the ones who are really doing the hard, basic research on the bench, and then the ones who would like to apply it to the patient, we as the treating neurologists. And that needs to go back and forward, because the good ideas for basic research really come from the clinical field. Very tiny observation on side effects, for example, can lead to new therapeutic development. So that needs to be done. And of course, for any individual patient, as the disease can be that variable, there should be some kind of definition or adjustment. How is the individual risk profile? So these are the vision which I would like as subheadings in order to achieve that in the future. So starting with that, I will now move on to another aspect of the disease which is very important, because there are different dimensions of this chronic inflammatory disease of the central nervous systems, depending on which view we take. We as neurologists, we are concerned about having good measurements, objective measurement that this medicine really works. So we want to have something in numbers or categories which we can quantify. So there are certain tests like this one here, the 9-hole peg test or other walking tests, something like that. And then, of course, which was a great help also for the development of new therapies, is the objective measurements of the pathology, what is really going on the brain of patients affected with MS. And by counting these lesions, you have an objective measurement to tell something about the burden of the disease, about new inflammatory lesions and things like that. But then, of course, we do have something which is very difficult to define, the quality of life. There are different scales already available, but we were not really used to use it as an outcome measure. And I will come back to this later on, that it's probably very important for future trials to take this into much more consideration. And then we also have learned that it's not only all about inflammation, but MS is also a degenerative disease where the axons, so the electrical wiring within the central nervous system, all of a sudden falls apart and thereby slows down conduction and make all these symptoms you as patients may experience. And then, of course, there's another important factor dealing with the disease. This is society. Because society is always concerned about cost of diseases. What kind of disease burden is it to society? And very soon they will ask, oh, these treatments are all very expensive. But here, look at this very small pie chart. 7% of the overall cost of the disease are only due to treatments. A major aspect is what this blue part here is, 43%, the indirect cost, meaning the cost which incurs as a patient, young in his life, stops working due to early retirement. So these are all issues which needs to be taken into consideration if we're dealing with development of new treatments. And then you have seen this already from Professor Montalban's talk. Then is actually the question we have to ask ourselves, are we looking at the right endpoints? are we agreeing on what is important for our patients? And this study was done in a way that neurologists were asked, what do you think is important for your patient? And the patient themselves should judge what is most important for me in terms of, again, categories on this quality of life assessment. And there were quite a bit of differences. So our view is more related to physical disability, and the patient themselves judge much more important emotional role limitations, general health and vitality. So taking this into consideration, we may view the different aspects of the MRI, like these two MRIs, which look pretty similar in terms of lesion load, but the difference of clinical expectation were quite different. This person just finished his PhD thesis in molecular biology. The other one here had severe cognitive impairment. So this is just to tell you that there is more about the disease which we can capture right now, and we have to be very aware about and innovative in terms of defining new clinical outcomes. Something we were much concerned or surprised to see when we did an evaluation of what is an ongoing effort of the German MS Association in order to come up with some clear epidemiological figures in Germany, which weren't existent on a nationwide base. And I will just give you a brief example of what of surprise you can come up with if you simply ask for the prevalence of certain symptoms. And we all know that, for example, spasticity is very common. In this cohort, 66% of the patient had spasticity, or bladder disturbances, 62%. But here's something which we weren't probably that much associated with, that fatigue also was present in 64%, and cognitive deficits in 36%. But what is probably more important is what is written on this side. This column tells you which of the patients didn't receive treatment for their condition. So only 31% with patients with spasticity didn't have any treatment. But here, 79% with fatigue and 83% with cognitive deficits didn't have any treatment for that, although it was so prevalent. And then you ask the question, oh, there's something going definitely wrong. Why don't they have treatment as the symptoms are so important? The answer is very simple. There are no evidence-based drugs available because there are no really good studies dealing with this issue and treating these particular symptoms. And then, again, as a result of this study, it was also, to our big surprise, that around 40% of patients in this cohort of 10 to 12 years disease duration, around 40% of these patients were already retired due to MS. So early retirement is an issue. And then the next obvious question is, what were the symptoms or what was the reason for early retirement? And it's not always the physical disability that patients are wheelchair bound. In this subcohort of patients we looked at in Würzburg, 30% had cognitive problems as their main concern, and then 35% had both a combination of physical and cognitive problems which were associated with early retirement. So it all comes to an aspect that we really need to look in this aspect a lot as well. So this is just one issue I wanted to address. The second one is what I think is also very much important is in terms of communication to the patient themselves about the disease. We all have heard about the stories, how difficult it is to convince patients to stay on treatment, to adhere to their treatment. And Siri just pointed out, though you may tell them it will get better with the injection, definitely it's not something you would like to do continuously. And then we have these nice figures like this one here telling you, there's inflammatory activity at the beginning and that will lead to severe atrophy. So it's very complicated. That's not really something you would like to tell a patient. It's nice for a scientific audience to give this type of presentation. So you need another medium in order to describe what's really going on in MS. And again, another initiative basically from Adam Michel, who just stood up from the German scepter of Baden-Württemberg, of the German MS Society, developed a very nice initiative to use new innovative media like these animated audio-visual components to have something about telling MS patient what's going on with the disease.